All right, we're recording again. Thank you to everyone who is joining us today from around the country and around the state. And I think we even have some international, I think we have some Canadians coming in. So just delighted to have with us two of the world-renowned experts on the topic of COVID, the vaccines, and all that we are dealing with. And so I am going to introduce Dr. Okwo Bele and also Dr. Nandy. I'm just delighted to have both of them. Dr. Okwo Bele has worked with the World Health Organization and was the Director of Immunizations and Vaccines at the WHO from 2004 to 2017, and is continuing to be a chief consultant as they respond to the COVID crisis. And he was very instrumental in the Ebola crisis as well. And Dr. Nandy is a former CDC epidemiologist and now chief of immunization at UNICEF in New York, and as we found out, is also in Connecticut as well. So it's great to have you here. And I am going to turn the picture over to Dr. Okwo Bele, and then as the two of you talk, I'll just go from one to the next. And I have apologies to everybody. I have not become perfected at the art of Zoom, but we're a forgiving organization here at the church, and we're gonna do the best we can. But we are just so grateful. And Dr. Okwo Bele is joining us from Geneva. And he is also, I will throw in, the stepfather to Naomi Ngoma, who's our outreach coordinator, and a true gift to Emanuel in so many ways. And this is another way which she shares her gifts with us. So Dr. Okwo Bele.
Thank you so much, Pastor Paula, for inviting both Robin and I to this group to discuss COVID-19. It's clear that all of us here have already heard a lot and discussed a lot about COVID-19. And we, as individuals, have certainly faced decisions regarding our protection and the protection of our loved ones. So actually, we look forward to hearing your views on what's happening around you, and would be happy to answer any technical questions that you might have on the disease, on the health impact of COVID, and also on the precautionary measures proposed. But before that, I felt that it may be good that I share with you, a few points with regard to how the world is organized to respond to the international spread of diseases. And Robin will follow with some of the remarks on the response measures, including vaccines. So 15 years ago, that's around 2005, the international community came together to create a kind of new law to prevent the spread of infectious diseases and other health threats. The law is known as the International Health Regulation, and it's a legally binding instrument of involving 194 state parties or countries. And the ideas behind that international regulation are not new, because for very, very long time, people know that what affects one country, one region can affect other parts of the world or the country. So unlike the previous versions of the regulations, which require that countries have to report on a few diseases like cholera, plague, yellow fever, the current new regulation is more flexible. It's future-oriented. It requires that countries must assess and notify any event, seen as unusual, seen as unexpected, even if the event's causes or the sources are not known. So long as there is a threat that illness can have a significant risk internationally. And you may want to know that for the past 10 years or so, WHO, the World Health Organization, has tracked almost 1,500 epidemic events in close to 172 countries. So one would say almost 100 epidemic events each year. But only a handful of those epidemic events have met some of the criteria that have been put forward for extraordinary events that have the potential to spread internationally. You may remember the 2009 influenza pandemic that was called H1N1. You certainly remember the Zika virus in 2016, especially in Latin America. You may also remember the Ebola virus that spread across into a few countries in West Africa, but also had importation of cases internationally, including in the US. And now, the COVID pandemic. So when WHO receives the notification of an epidemic event that is important, the Director General of the organization is required to make a formal declaration if the assessment of the risk is such that the potential is felt to be great in terms of further dissemination of the disease. While making the formal declaration, WHO also issues recommendation and advice to countries, both the countries that are concerned, affected, but also the countries, the other countries, the remaining countries, so that they can get prepared. And I would like to quote what WHO advised countries to do back in January with regard to COVID. So it says this, I quote this: "It's expected that further international exportation of cases may appear in any country. Thus, all countries should be prepared for containment, including active surveillance, early detection, isolation, case management, contact tracing, and prevention of onward transmission of the new COVID infection, and to share full data with WHO." So this communication has gone to all countries, but at the same time, WHO has put in place guidance and training materials so that health workers and managers in the countries can start working on this. But also, WHO has put in place a series of research activities, which we can discuss later. But one of the shortcomings in these international regulations, and I would like to really insist on this, is the lack of enforceable sanctions. For instance, if a country fails to explain why it has adopted more restrictive traffic and trade measures than those recommended by WHO, there are no legal consequences, because WHO has no independent authority on the countries, the member states that created it. And that's in the Constitution. So it's a big shortcoming. So now, after 9 long months of living with the virus, we kind of see a divided world. There is truly a striking diversity in the pandemic dynamics. For instance, most countries in Europe in North America are now facing a terrible, terrible second wave of the pandemic. Here in Switzerland, things are really worse than it was, during the first wave. But at the same time, we see that Asian countries, and some of these countries are democratic and some are not. And countries such as Australia, New Zealand, they have proved that it's possible to force infection rates so low as to more or less eradicate the disease. So you have noticed that forecasting the course of the disease have been somewhat difficult. We get into cold weather, in the northern part of the hemisphere, putting people, more indoors where transmission could be higher. We are getting close to end of year celebrations, Thanksgiving for you in the Americas, and then Christmas and other festivities here, elsewhere, and including in the US. And we know that politicians may not want to take all the blame for lockdowns and canceling the holidays. So we stand to see, how this will unfold. But one thing is clear, one thing stands out. We all know how COVID-19 is transmitted. Respiratory droplets of infected individuals, that these are the main of transmission. And the illness is also transmitted through contact with contaminated surfaces. So the best approach to wipe out the disease is for people, each one of us, to know the risks, and for each one of us to decide how to protect others and to protect ourselves. Government, local administrations, and others, they're there with the mandate to support us, support communities, support the country, so that, through proper communications, we can all take the measures that are required. So these are some of the initial remarks I wanted to make, mainly to insist that there is a way for countries to get together and agree on the course of actions, but there are, as for many initiatives taken internationally, some shortcomings. Paola, with your permission, I'll ask then Robin to take over, and then elaborate a bit on some of the response measures, including where we stand with vaccines, and then together we will look at how to respond to any question that may emerge, but also listening to others, based on the experiences that one can share. Thank you.
That sounds fantastic. I know one question I'm going to have is, what's the difference between Asia and Australia, New Zealand, and us? But we'll come back to that. But that's very interesting. Dr. Nandy, here you go.
Thanks. Really happy to be here and with Dr. Okwo Bele, and I'll just build on Dr. Okwo Bele's introduction with I'm going to just take it more to the into the intervention mode. So obviously, different diseases have different transmission dynamics, and as Okwo mentioned, COVID is spread through the respiratory route. But even so, the transmission dynamics are quite different in different countries, different communities, depending on a lot of factors. Population distribution, where people live, the amount of proximity, social, the kind of social interactions in the community. So. All this to say is that we live in a diverse world, and this diversity plays out even in disease transmission. So again, as we go into the next phase of COVID transmission, it'll be really important for countries and communities within countries to really tailor their control and prevention interventions to their particular context and need. The second thing to say is we are learning every day more and more about the transmission dynamics and what is protective and what's not, and we are getting new evidence all the time. And I think it's really important to understand that because we are uh, rapidly evolving our guidance as well as this new evidence comes in. So I think as you pass your messages to the church communities and so on, and have questions in terms of why guidelines and recommendations are changing rapidly, they're changing because we're learning new things about the disease. I mean, the masks, for example. Initially, we were not recommending widespread use of masks. We were prioritizing. There was also a global shortage of protective equipment, and we wanted that prioritized to health workers to protect them. But then, as we got more information, we have increasing evidence that masks are an effective measure to prevent. So. Uh, Guidelines and recommendations will continue to be evolved, and that's actually a good thing, because if we get stuck on one recommendation and don't change it based on evolving science, we are doing a disservice. um, Globally, I think we are looking at an unprecedented effort to actually accelerate the development and distribution of new tools to fight COVID-19 pandemic. This includes vaccine, which I'm going to talk a little bit about because that's my current job and my role. But also to say that vaccines are not the only things that are being developed. There's a lot of research and efforts going on for therapeutics, treatments, as well as diagnostics. And as we know, all these need to come together. None of these alone can have an impact on the outbreaks, as we know from other outbreak prone diseases. The vaccine, an availability of vaccine would not negate the importance of good treatment and diagnostics as well. So I think the world has come together in the initiative called the access to COVID 19 Tools Accelerator. It's a multi agency, including private sector initiative to get these new COVID tools, including vaccines, to all parts of the planet. This is an unusual situation. We are developing new tools that need to be deployed right across the globe. Low income countries, middle income countries, high income countries. It's unprecedented that we've had to do something so rapidly. Talking now a little bit about the vaccine, you've all seen articles in the New York Times and elsewhere on the Pfizer announcement that the phase 3 trials are going well, and early evidence indicates high effectiveness of the vaccine. This is really good news. But I think there are a lot of challenges ahead as we deploy this vaccine. First, you've got to decide who to vaccinate, then how to get these vaccines to these people, and then to the communities, and then finding the people to vaccinate. Um, and I think the planning has already started. It actually started even as the vaccine trials are going on. Um, Understanding the fact that early in the introduction of vaccine, the number of doses are going to be limited, and they'll have to be prioritized very carefully. Not everybody who wants the vaccine is going to get the vaccine. Um, the global recommendation currently is to prioritize this limited doses of vaccines to healthcare providers and those in direct contact with patients to protect the health system. As we know, the health system is being overwhelmed, and that's true in many countries in the world, including the United States. And you see that in the news even this morning. The Some of the new vaccines have very challenging storage and transport requirement. Some of them require ultra cold chain, which needs minus 70, minus 80 degrees Celsius. Few countries have the capacity. in order to do that. So the key is to rapidly build up capacity in these countries, and their training needs. Most countries outside the developed world are not used to giving vaccinations to adults and to the elderly. In Europe and North America, you have influenza or flu vaccine programs which reach these populations, but many parts of Africa and Asia, there is not the experience to reach elderly and adult populations. So there are training needs that need to be put in place. But one thing I want to assure you and your community is that um, the most important thing for us as we deploy vaccine is safety and effectiveness of the vaccine. And there is a lot of talk about how is vaccines development accelerated so quickly without cutting corners, without risking safety signals and checks and so on. The reason we are able to move so fast and really fast because our previous experience, the quickest a vaccine has been developed and deployed has been 4 years for mumps, about 5 or 6 years for Ebola. We are doing this in a year or 18 months for COVID-19. The reason we are able to do this is that the world has come together, developers working with manufacturers, working with people like ourselves who actually will be tasked to deploy the vaccines, all working together in parallel. A normally linear process which would wait for development to be completed, all phases of trials to be completed, and then preparations for rapid manufacture of large amount of doses now are happening in parallel. The only risks that are being taken, and this is not in the area of vaccine safety and efficacy, the risk that is being taken is in investments, because a lot of investment is going into manufacturing capacity even before we know whether the vaccine is going to be successful or not. Some of the vaccines are not going to make it, and some of the early investments in manufacturing are probably not going to materialize. So that is the only risk that is being taken right now is financial. Also to say that we should not get complacent when a vaccine arrives. A vaccine is not going to be a silver bullet that we can stop doing everything else that we need to do because we have a vaccine. um, we have seen this with other vaccines as well. With the, when we deploy the cholera vaccines, people, drop their attention on good hygiene, good sanitation, good hand washing, and that is counterproductive because vaccines need to be deployed with other public health interventions. So as we deploy a vaccine, we still need to focus on treatments and diagnostics. We still need to do what we are doing today, distancing, wearing masks, hand washing. I'm going to end with a few final remarks on the concerns that I have, or things that keep me up at night. Is as we prepare and as we respond to this terrible COVID pandemic, we cannot take our eyes off the ball on the other essential services that are being impacted by the COVID-19 pandemic. Um, all sorts of other health services have been interrupted because of diversion of attention, diversion of human resources, diversion of financial resources to the COVID outbreak. Uh, Other services for other essential healthcare services have been jeopardized, including immunization, including newborn care, including emergency obstetric care, things that we can't afford to interrupt even for a day. If a child is born, we can't stop that, and we need to provide newborn care to that child. Immunization has been impacted in many places. Were ground to a standstill in April or May this year. Why? Because of diversion of resources. But oftentimes, even if services were available, people were unable to go and get these services because of lockdowns, transport disruptions, and so on. So, we urge the scientific and the health community to try strike a balance between COVID and other health services. We have seen last year in Dr. Okwo Bele's home country of the Democratic Republic of Congo that more kids died of measles as we were deploying the Ebola vaccine in eastern Congo. Of more people died, more children died of measles than people who died of Ebola as we were deploying the Ebola vaccine. So it's really important not to trade one health priority for another and strike a balance. My second concern is the erosion of trust and the fact that the outbreak and public health, in a sense, has been politicized. I would urge us all to really ground what we do and the recommendations we make ourselves and the recommendations you follow to be based on sound evidence and science. And then my final concern is the impact outside the health sector. We've talked a lot about the health sector, but UNICEF is a multi-sectoral agency looking at the impacts on children. And I think, one of the things you hear a lot is, yeah, children are not impacted much by COVID, so they are not a priority. However, children are impacted in many, many ways in this COVID-19 pandemic. The education is in jeopardy in many parts of the world. In many parts of Africa and Asia, homeschooling is just not realistic. They do not have internet, computers at home to continue studying. It's taken a mental health toll on children and families. So these broader and of course the economic impact, which is going to play out in years to come, and it'll take a long time to recover. So just want to highlight a few of these, but happy to answer specific questions. Back to you, Pastor.
Thank you. At this time, I'm getting some questions in. One of the first ones I'm going to ask for both of you, because I know there are a lot of clergy on this, and they're going to be sharing it with their parishes. Some churches are getting a lot of pressure to have worship inside. I will say that I'm very grateful for Emanuel and our leadership. We have a wonderful team that's been addressing that. But I would like to know from both of you how safe and healthy you think that is, or if it will lead us to meet our Heavenly Father quicker that way. So appreciate your feedback. Whoever would like to go first, tell me, Dr. Nandy or Okwo Bele, and I'll highlight you. Do you want to go? We'll unmute you.
Yes. So if I understand well, you're talking about the resumption of worships with all communities coming together. Is it?
Yeah. Mm-hmm.
Yeah. So I did say that all is about applying what we know in terms of the disease transmission dynamic and the protections, first the risk and then the protections that one has to take. At the present time, I don't know exactly the situation in your neighborhood, in your community, but overall, what I've seen,
it's red.
Yeah, it's red. So it's like here, it's red. The principle is to avoid the 3 C's. I don't know whether you've heard that. So you avoid the spaces that are closed, that are crowded, and involved close contact. So if you go from that principle, then, you have some of the restrictive measures that have been taken. No gatherings indoors of people not belonging to the same family, more than 5 here, for instance, in Geneva, or 10, or depending on the situation, as Robin said. So that's the principle. And it's not so much that people, when they get together, they will not protect themselves, but the risks are, with masks, for instance, with social distancing, may be low, but they are not completely nil. They are still, you still have risks. People will tend to hug themselves. When you come to meet people after so many times, you have to meet in places of refreshments. You meet in the toilets. And then as people move into some of these gathering places, they tend to socialize, and sometimes may be difficult to impose strict restrictions. That's why, some of these restrictive measures are so compulsory and so difficult during the period when transmission is high. I don't know, Robin, if you have more to say, but I think it's just about, Pastor, and you will understand. It's about applying in a what one would tend to say. You use common sense, and then you say, how am I going to protect my community, and what should be done for that?
The greater good. Yes, thank you. You have reaffirmed, and I know for many of us who are clergy, hearing that from people of your educational and ability, I think will help a lot of us as we deal with our congregations, that it's the bigger picture. And those 3 C's I know were helpful to hear. Dr. Nandy, do you have anything to add to that?
Yeah, no, I think Dr. Okwo Bele really highlighted it well. I think it's got to be a combination of common sense and along with locally adapted guidance that is provided by the health authorities. And I think the risk is there. Any large congregation in a closed place, whether it's a church, other religious establishment, or whether it's a gym, any other closed space with a lot of people there, if it can be avoided over this coming months, where the transmission is actually higher than it was in April and May this year. So I think we've got to really take this seriously, and where avoidable, try to avoid the large congregations. Where it's not avoidable, obviously, they recommend people to take precautions, wear masks, stay away if they're feeling ill. That's an important one. If you can, limit the numbers at least. But where possible, do avoid congregations in closed places would be my recommendation.
Okay, I've gotten some questions that have come in. There are 3 here that I think will be pretty quick, but I think really important. And this one's bothered me too. It says, is it recommended to sanitize while wearing gloves? And I admit to getting a little concerned when I see servers come to my table with their gloves on, and I'm wondering, but they're touching my stuff. So how does that affect things, and what do you need to do with gloves? Whichever one wants to go, I'll click on you.
Okay, I can start this time, Okwo, since the camera is on me. Yeah, I think, look, every measure, preventive measure, or every tool or whatever we use to prevent is as good as how we use it. And how we use gloves, how we use masks is actually going to determine whether it's going to be useful or not. So if you use gloves with for long without changing it. You could have the complete opposite effect of what you're trying to do with the with the gloves. Similarly with the masks, I mean, you see so many masks hanging around people's chins and not covering the nose. And uh, you, one of the reasons why the early evidence on mask use was not very conclusive either way is because a lot of people don't use them appropriately and don't change them. They don't wash the mask. Now, if you don't wash your mask regularly with soap and water and use it for several days, it can start harboring all sorts of microorganisms. So every tool needs to be used properly. Otherwise, it won't have the right impact. And gloves are the same. I mean, you've got to change gloves frequently. Again, if you're hand washing and sanitizing, one would question whether you really need a widespread use of gloves, and just leave the gloves to healthcare professionals. Who are in direct contact with patients.
And I tend to go for the blue surgical mask, not the cloth mask. Is there and I don't know why, but is there a preferred mask? I do. I can breathe better through this, but I'm wondering if there's a preferred mask from a health standpoint.
You can use either, but the disposable one, you got to dispose on regular basis. The cloth mask, you got to wash on a regular basis. So, no, you could use either.
All right. And then I'll move to you. I'll kind of rotate between the two of you. The next question I have is, how does exercise affect COVID? Is it recommended to do so while following precautions? Are there any concerns with exercise?
Actually, it's recommended that one does exercises every day, at least minimum 15, 30 minutes, for keeping yourself in good shape. What is being prohibited or discouraged is to get again together as a group and exercise that way, especially indoors. But otherwise outside exercises actually must be encouraged, should be done.
Is there some type that's better? Like if you're swimming in a pool, is that because there's the chlorine and you're not drinking the chlorine, but you're swimming in it? Is that safer than like in other kinds of working out or not?
I think all kind of exercises, so long as there is no, the issue is about, being in contact with surfaces that are contaminated or being in contact with a person.
Okay.
For the rest, any sport, football, whatever, can go on without any problem.
The next question is taking temperature realistic and as a realistic aid in preventing COVID? Most of us go, and I don't know if it's true in Geneva, but where our temperatures are taken before we go in places. How realistic is that?
I think at least it shows on the spot when the person getting in a in a facility, in a plane or whatever, whether at that time the person has fever, and if the person has fever, then one needs to be a little bit more cautious about how to handle that. It doesn't mean that fever equals COVID, obviously, but at this time, when somebody has a fever, you better be a little bit cautious, because you don't know what's going on there.
So it's more of an exclusionary. It's basically, it doesn't mean if you don't have a fever, you're fine. It means if you do have a fever, stay away, stay away.
That's better, yes, indeed.
Great. The next question is for Dr. Nandy. The next question is for him, Dr. Nandy. What percentage of the population needs to receive a vaccination before we can expect a decrease in infection rates and mortality?
Yeah, that's a great question. I saw it on the chat. I was actually going to answer that as well. David, thanks for posing the question. Look, different diseases have different levels of what is called, you've heard this terminology before. The aim of vaccinating large number of people normally for most communicable diseases is to achieve what is called herd immunity. And now herd immunity for different diseases can range. It could be, 65-70% for some. For measles, it's actually 92%. Need to be vaccinated to have herd immunity. To be very honest, for COVID-19, we do not have a definitive data or evidence to suggest what the level of vaccination coverage will actually reduce transmission. We will learn about this as we go along, but right now, we have to assume it's somewhere between 70 and 90%. What we do know, however, is that in the early years of vaccine deployment, there will not be anywhere near the number of doses available to vaccinate that high proportion of a population to reduce transmission. That is why the initial use case for vaccine is targeting health workers, the elderly, those at high risk with comorbidity. So the initial deployment of vaccine is not meant to affect the transmission of the virus or bend the curve of the virus, but to prevent mortality among those most at risk, and to keep the health system going so that we don't have disruption in health services that affect not only patients of COVID-19, but other infections. Remember, other infections and other diseases have not gone on holiday just because COVID is there. We are seeing all the other normal diseases that we see in communities along with that, and that we need to focus to. So the road to reducing transmission through vaccine alone is going to be a long road, and that's why I say that no one intervention by itself is going to be successful. It's going to have to be in a combination. We've got to find the cases early. So diagnostics very important. We've got to give them treatment, and we've got to remove them from exposing other people. So isolation. So test, treat, isolate has to continue along with any vaccines that's deployed. And remember that even if when a vaccine is available, a vaccine is never usually 100% effective for everybody. So the Pfizer vaccine estimated efficacy is 90%, which is really, really high for a vaccine. But still, out of 100 people given the vaccine, 10 people will not be protected by the vaccine because they will not mount, it won't result in the creation of antibodies, and they'll still be susceptible. So again, I stress my point that please don't view vaccines as a silver bullet. It needs to go with other initiatives, although we are very excited that vaccines just aids us, gives us another tool to address COVID-19, the COVID-19 pandemic?
And if I may add, Pastor, that
Yes.
you, for that vaccine, you may even 2 doses, that's also add to the complexity. But remember that, as I was talking, I mentioned that some countries have been able to almost suppress the disease without vaccines, because the current measures, when they are well applied, can lead to almost the eradication of COVID. Australia, Asian countries, and so on. What they did there is that after the lockdowns that have been implemented almost everywhere in America and Europe, there as well in Asia, they continued to be very rigorous in applying the follow-on measures of detection, contact tracing, isolation of cases, and so on. They have been very rigorous in doing that. While in Europe and certainly in the Americas, during the summer holiday, there was a bit of relaxation there. Some people would call some of the measures implemented in Europe, America, as containment strategies, while others, truly they went for suppression strategies, just trying to get rid of the disease. And that's another step, to enforce what needs to be done and what is known should be done, actually.
And then I'll throw up one of the next questions was, any thoughts on how to reduce or reverse the politicization of viruses and masks, etc.? And I will add to that, is there any hope that now that the that it's been opened, is it Pandora's box and we can't get it back, or could a shutdown get us back to the point where we can deal with it?
I think politicization is just for masks. We see it also a little bit with vaccines and with other measures. So it shows a little bit of distrust, between politicians and the populations. I think WHO, well, the countries, when they came together and agreed on the international regulation, they said that each country must have a focal center, to deal with all these outbreaks. We call it national focal centers. Certainly in the US would be CDCs and others. And so these technical bodies must be given the resources, must be empowered and be enabled to provide the best advice to the decision makers, who then should be able to explain it to the population. So that's part of the technicalities has been missed here and there, unfortunately, and we saw that the decision makers did not follow necessarily all the advice that they were supposed to be getting from some of these technical bodies. And truly, these technical bodies, there's a lot of exchange happening across the world now, to exchange on the experiences and so on. Again, what we're lacking in this architecture is a kind of overarching mechanism that will help to enforce some of the implementation or some of the factors that will facilitate implementation in all countries. That's really missing.
Will the US rejoining the WHO help at all?
Well, we hope that the US will never step away, because I think viruses will continue to circulate regardless of borders and so on. And all we need each other in these kind of things. And in addition, the US has a lot of great experts that have been helping the world. So, but on the other side as well, to make the vaccines, you need to access the viruses. And if the viruses is at the initial stage, the virus was only in China, for instance. So the sharing of viruses, the sharing of information is important for each country, including the US, for them to be properly prepared and mount a great response. So I don't think that it's a good thing that any country, gets out of this global kind of, regulation.
Dr. Nandy, do you have anything to add to that?
Yeah, no, I mean, I think, I think this pandemic really highlights the need for global solidarity. And no country can deal with this by themselves. And we are seeing this. We are seeing this in the response, the evidence that's been generated in different parts of the world. The sharing of information, as Dr. Okwo Bele says, is extremely critical as we learn more and more about the new disease, and we can actually tailor our strategies more effectively. So yeah, it needs the world to come together, to be honest. And I think it is counterproductive if a country as powerful and as scientifically strong as the United States stays out of the World Health Organization. It's not good for the world. It's not good for, I would argue, it's not good for the United States. So we would, and we are a multilateral organization at UNICEF, just a sister agency to the World Health Organization, and we would like to see the world coming together and in an act of solidarity here. Pastor, there's some questions targeted at me. Do you want me to take them one by one? Or?
Yes, actually, that would be great. And then the next one, actually, I'm going to add something to it. How can you determine the safety of food prepared by other people, both community members and restaurants? And I'm thinking also in terms of preparing treats at Christmas, because that's one of the things I do, and I know others do. What are some concerns about that?
Yeah, I mean, this is a good question. But remember how COVID-19 is spread. It is spread. It's airborne transmission. It's transmitted through the respiratory route. It is not transmitted through food, as Dr. Okwo said. It is through interpersonal contact. It's through viruses sitting on various surfaces and so on and so forth. You're not going to ingest the virus through food. So it's not a question of how the food is prepared, but it's more where the food is prepared. If it's in a closed environment and a lot of people together cooking, and then these same people going out and serving and coming into contact with the people who are receiving the food. So remember, mode of transmission. It's not going to be the food per se, but it's actually going to be the interpersonal contact in the preparation of food and in the distribution of the food. So I think that's really important to note.
Do you go through some of the other questions that are there between the two of you?
Sure, I'll just scan this very quickly. There's one on what does UNICEF say about protecting children in schools. This is a great question, and again, I think we have global guidance on this, but the real specific guidance will be country by country. There's been huge efforts and improvements in digital learning, remote learning in many countries. New internet-based tools to facilitate learning. Remote learning. So that's definitely some an area of growth. For education. And of course, there's, in many countries, recommendations are being made by UNICEF, globally, on how to get kids back in school as safely as possible and how to protect them from being sources of virus transmission. There's a comment about teachers also coming into contact with with children. So adherence to protocols in terms of, staying within your bubble, and being careful when you mix outside the bubble. And as soon as a case is detected, very good contact tracing in schools, and then isolating the people who've been in contact with case patients. I see that here in Greenwich, in Connecticut, where they're doing very rigorous regular testing of suspected cases. And as soon as somebody tests positive, they go and do a contact tracing, and then have people isolate contacts isolate in their homes to prevent onward spread. So there's a comment on mandating mask wearing, like seat belt and motorcycle helmet. Yeah, I mean, look, I mean, uh, there are a number of schools of thoughts on that. Obviously, helmets and seat belts, use did increase once the mandates were there. But now I don't think people wear seat belts because of the mandate. It's just become a habit now. I'm of the generation where in the old days, your parents would say, "Put on your seat belt. The cops will fine you." Uh, the narrative has changed, but now parents telling their kids, "No, put on your seat belts. You want to be safe in the car." So again, I mean, I think mandates can drive up to a certain point. There's also a risk of mandates sowing even further mistrust, particularly when there's mistrust already there, between the state, the government, and the community. And anytime a mandate is issued, there's a there are arguments and discussions on individual rights and so on. I think as a public health professional, I would like people to voluntarily appreciate the benefit of mask wearing, and voluntarily, practice mask wearing and promote it within your families and within your communities. There's a question on mutations. Yes, I'm aware of this Danish experience of the virus moving from mink. Again, I think it's early days. We're still learning about this. Obviously, there's still a lot of unknowns. Not only on mutation, but even in terms of immunity induced by infection. Once you have an infection, how long are you immune for? We don't know how long a vaccine is going to confer immunity. Is it going to be 6 months, a year, longer? So a lot of things still, to be worked out, and this is a rapidly evolving field. We are learning new things every day. Um, uh, uh,
There is one on whether plastic face shields are effective without, the mask over nose and mouth. I think we strongly encourage that people wear masks over nose and mouth and wear them properly, and not just the plastic face shields. That can be added on eventually, but not put solely.
I did have a question here that was thrown in. It says, how should we modify other ministries that involve contact but not indoors, carry out meals? And then added to that was one that added any advice for volunteers for our pantry or people that work in the community that have to have face-to-face contact.
I think we should help people as much as we can, but we know what the risks are and how to protect ourselves and protect the others. So, having the face mask properly wear, and then having, to keep the distance with, the people we are serving. After, we have, for instance, get to them to provide them with either food or drinks or whatever. There are several ways of doing this without certainly getting to hug each other or getting too close, including outdoors. I think that's critical. So long as you are in contact with people who are not from your household, I think the precautionary measures must be implemented fully, and one should not have any confidence that the others have necessarily taken all the precautions themselves, and similarly, the others should not feel that all the volunteers are necessarily all the time well protected. So I think again, maintaining the basic principles at any time, covering the face and maintaining distance, avoiding visits whenever it's possible. That these are the kind of things.
There was also a question added about the eyes and should we be wearing goggles? I heard a study that said people with glasses actually do better with preventing COVID. Is there any idea about wearing goggles or glasses for preventing?
Well, imagine if already everyone has a mask, you reduce even the likelihood of having droplets to the eyes, no? That's of the other person who is in front of you. But the most important is nose and mouth, I think.
One other question, we had one other question I'm going to add into it. What initiatives are being enacted to make sure that the virus gets distributed equitably worldwide? And I'm going to throw into that. It's my understanding that it's it hasn't really hit Africa as much yet. I know a couple of the refugee villages I work with, they've had more problems with typhoid than COVID. Are they expecting it to hit there, or is it just a matter of time?
No, the virus has spread to all countries and continents, including in Africa. The magnitude of the spread is somewhat much reduced in the African continent. Maybe in part because we don't have all the capacity for testing, but also the fact that these countries have had very early lockdown measures, and understand also that the contact between Africa and China was stopped truly as soon as cases started to be recognized in China. And we know that travels from Europe also were blocked. So overall, apart from South Africa, and then a little bit the northern countries like Morocco and Algeria, most of the countries in Africa did not have a big wave. Population is young. And also, people are most of the time outdoors, so a lot of factors they explain.
How about the initiatives being enacted to help make sure that the vaccine gets distributed? The virus has definitely been equittably distributed.
I was about to say that can only be vaccine, not virus, because we don't want to distribute this evenly. Hopefully, no. I think my colleague Robin talked about the facility that has been established here in Geneva through WHO in collaboration with UNICEF and many other players, Gavi and many others that are supporting immunization activities. So the initiative is about having most countries to access vaccine through one platform, that's COVAX facility. And the distribution will be done normally according to the epidemiology and so on and so forth. The modalities are being discussed. And then for countries that are not well resourced, they could be, and they are actually a bit of help, coming, including from some of the rich countries. But we still have some work to do before getting to this equitable distribution, because the rich countries have gone ahead and made very elaborated contract with manufacturers. That's difficult to completely put aside. But we believe that because there are at least 10, 11 vaccines that may be available by the end of the next year, early 2022. So the likelihood of getting to distributing this equitably is there.
Well, we want to honor your time, so I want to see if there's any. I think we've answered most of the questions. Any final comments from you, Dr. Okwo Bele and Dr. Nandy? We are so incredibly grateful. I thought I knew a lot about COVID before this, and I feel like I'm walking away from this so much more knowledgeable.
Wait, before you go, there's another question that just came in, which, with the holidays.
How safe is it to travel on planes and trains? I think so far there has been a lot of measures taken to avoid transmission through travels. Remember that before you take a plane, I don't know in the US, but internationally here at least you have to have a test that is negative, but then they have to take your temperature, and then inside you have to wear masks and keep some distances. And then they replace the air that is circulating in the plane as moves about. Same for trains. So there has been not much description that I know of clusters of cases from planes and trains. But again, it's about individual protections. And that would be also, Pastor, my last comments here. Is to say the times are truly hard. It's a difficult time for everyone. It has taken too long. 9 months, and it may take another few months before we get to some other levels of activities. But I think this is not the time to let the guard down. So I think this is the time where through exercises and through peer support that we can do through virtually or once in a while, walking outside together. It's a time to support each other so that we can go through this and then accept in a deliberate manner that some of the things we were used to, like going to the worship places and so on, are not done as one would wish. But it's a matter of a few months now before we get there. Because truly, the stories that we get from people who got the disease is not good. In addition to the loss of lives, those who survive truly are not, especially those who are in the 50s, 60s. They truly regret that they could go through those experiences. So let's protect ourselves and protect our loved ones. Ensuring that the protective, the precautionary measures are well implemented as much as possible. Thank you.
Dr. Nandy, I'm going to turn it over to you for some final comments.
Yeah, not a lot to say now after this, but I just want to add to Dr. Okwo's response to Carla on equitable distribution of vaccine. That's what we are attempting, but let's also appreciate, and good if you appreciate, that we are in unprecedented territory. We've never actually tried to deploy a health product across the globe and the same product, which is where high income, middle income, and low income countries are competing for the same product. Normally, by the time we deploy a product to a low income country, the high income countries have already got it. And we are trying to now make sure that the COVID vaccine diagnostics and therapeutics are actually much more equitable in their distribution. And that's the COVAX facility is actually a pooled procurement mechanism where countries actually invest money into this mechanism, and that assures them a certain number of doses for their population. The benefits of countries investing in this pooled procurement is the fact that they don't have to make guesses on which vaccine is going to work and which vaccine is not going to work. They put the money in this pool mechanism, and they will get one of the vaccines that actually works, rather than bilaterally cutting deals with various manufacturing and guessing which vaccine may work or may not work. And as Dr. Okwo said, for 92 of the lower income countries, there's going to be financial support to purchase the vaccines, because the country budgets would not be able to afford that. So we'll have to see how this pans out. It really depends on all countries playing ball, having a certain amount of global solidarity to see if this will work. But we are trying to ensure equitable distribution of vaccines, and I really hope we are able to do so. But protect yourself, stay safe, as Dr. Okwo said, and it was a pleasure being with you for the last hour and a bit.
Thank you so much. We are so incredibly honored to have had you. We have taped this, and we will be posting it on the Emanuel Facebook page and sharing it on the New England Synod. So share it with others and your worship teams. This has just been an unbelievably incredible experience for us at Emanuel to be able to host this. We're grateful for you, Dr. Nandy and Dr. Okwo Bele, and also again, thank you to Naomi Ngoma for organizing this. And may God keep you all safe. And to you, Dr. Nandy and Dr. Okwo Bele, I know I speak for many on this, and I say that we are keeping you in our prayers as you continue to be leaders in this. We are so grateful for your willingness to use your gifts and your abilities to truly seek to save the world. And as we who serve the one who saved the world at a larger standpoint, we're glad for those of you who are seeking to help us in a global way. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye, Okwo. Bye.
Bye, Robin.
Bye.
Talk soon.